Thank you very much for coming to this presentation, Lung Cancer Screening, Challenges for Vulnerable Rural Populations. I have no disclosures. In this talk, we will have a brief introduction of lung cancer screening. We will discuss the history of lung cancer screening, roadblocks to implementation. We will review what do we know and what do we need to know. We will also review some solutions such as thinking outside the box and creating solutions in future directions, and we will finish with acknowledgments and questions. Lung cancer persists as the leading cause of cancer death among men and women in the United States and accounts for more deaths than those of colon, breast, and prostate cancers combined. The American Cancer Society estimates approximately 235,000 patients will be diagnosed in 2021, with an estimated 131,000 cases resulting in death. Treatment efforts at the earliest stage have proven most promising. However, 5-year survival remains dismal at 46%, and overall survival remains poor at 17 to 21%. When we take a look at lung cancer, screening has revolutionized the way that we are able to treat this disease at an earlier stage. In 2011, data from the National Lung Screening Trial, a multi-institutional randomized controlled trial of more than 50,000 patients, formally demonstrated the utility of lung cancer screening by comparing low-dose CT with chest X-ray. They reported a 20% lung-specific mortality reduction and a 6.7% overall mortality reduction in a high-risk cohort that underwent low-dose CT. As a result, many professional organizations adapted these guidelines in terms of creating screening guidelines for high-risk patients. Those initial guidelines included patients 55 through 77 years old who were current smokers or had quit within the last 15 years and had a 30-pack-year smoking history. They also had to meet other criteria, including a life expectancy greater than 3 years, no other known malignancy, be willing to undergo treatment, and have no major comorbidities that would prevent treatment. Lung-RADS scoring was adopted in 2014 to help streamline the interpretation of these CTs. Modeled after BI-RADS, it was created to standardize lung cancer screening by conferring a probability of lung cancer, providing associated recommendations, and decreasing the 23.3% false positive rate found in the National Lung Screening Trial. It's a required metric from the American College of Radiology, accredited lung cancer screening programs, and programs must submit data to the National Radiology Data Registry. Unfortunately, lung cancer screening was tainted by an incorrect reporting of a 97.5 false positive rate when results from the NLST were first published. This was despite the fact that the NLST actually reported a 27% false positive rate. This news was propagated through many medical communities, and it made providers hesitant to refer patients. Even today, this number is still quoted, despite the fact that current estimates are much lower. For example, in 2018, the ACR had reported a 15% false positive rate, and here at Dartmouth-Hitchcock, our rate was as low as 5%. Nevertheless, many trials have progressed since then, including the Netherlands trial, which again demonstrated a decrease in not only lung-specific but overall mortality with the use of lung cancer screening. And a new adopted guidelines have been created given the lack of inclusion of those that have either started smoking earlier or don't reach 30-pack years. Hence, the new guidelines include those that are 50 to 80 years old, have a 20-pack year history instead of 30, and currently smoke or have quit within the last 15 years. So where are we today? Well, despite these recommendations, a disproportionate number of eligible patients are still either not referred or do not follow through with lung cancer screening, which leads to excess and avoidable deaths each year. Recruitment and enrollment in rural populations are even more discouraging, and while the reasons for this are likely multifactorial, Patient and provider roadblocks have historically been one of the most common barriers to participation. Thus, we need to better address reasons for low engagement to help improve the circumstances of this public health dilemma. So what specifically are these roadblocks to implementation of lung cancer screening in rural programs? If we look at this graphic published in the Journal of Surgical Research in 2021, there are multiple reasons, but they can be broken down into patient barriers, patient and provider barriers, and system barriers. Looking at the patient and provider barriers, smoking cessation requirements, provider lack of knowledge and bias, electronic medical record hassles, and shared decision-making, one of the biggest stumbling blocks has been a barrier that has been difficult to overcome. When we look specifically at patient barriers, patient distrust and stigma, including distrust of the medical system and screening tactics, as well as the stigma associated with smoking and lung cancer, has prevented high enrollment. Specifically looking at the rural populations, distance to an accredited center has a significant influence on whether or not these patients get screened. Lack of accredited centers and scanners, low-dose chest CT reimbursement, and shared decision-making reimbursement are systematic barriers that help to keep enrollment numbers low. Going back to the stigma associated with lung cancer screening, from the patient perspective, we know that diagnosis and treatment of lung cancer has tremendous psychosocial consequences. The highest levels of cancer-related shame are associated with lung cancer patients, and they experience the most stigma. They also have the highest rate of cancer-associated suicide. We know that patients worry about their coping abilities of their nuclear unit in relation to caretaking and discuss dealing with their possible death. And then while the effects of survivorship are well researched, which looks at the time period after diagnosis and treatment up until the patient's death, efforts are lacking in evaluation of the early psychosocial patient experience, especially those experiences revolving around screening. So what do we know? Knowledge is certainly power. Well, if we look at rural populations, for example, we looked at the population here in New Hampshire and Vermont, we saw that of the 558 patients that were excluded for not undergoing low-dose chest CT, key findings were that rural patients were less likely to undergo this and follow through with the program, demonstrated by our 58.5% follow-through rate. However, we saw that 68% were diagnosed with early-stage disease requiring surgery alone. Prevalence of lung cancer at the first screen was 2%, which was almost double what was seen in the NLST of 1.1%, and provides compelling reasons to further investigate patient facilitators to participation in rural communities. We also know that in defining the rural lung cancer screening experience, population distributions can demonstrate one phenomena, whereas the distribution of adult smokers can be in totally separate areas. If we look at the areas that have accredited lung cancer screening programs, we saw that low-dose screening centers have increased 8 times since their inception in 2014. However, disparities exist in the distribution of the centers in rural areas. Most importantly, areas of high tobacco use and lower education suffer from greater distances to accredited screening programs. This disparity in access is troubling, and given the higher incidence and later presentation of lung cancer within these populations, more study is warranted. When we've actually looked at a lung cancer screening population, we've seen that 82.5% of the screened patients presented with clinical stage 1 disease versus only 66% of non-screened patients. 83.3% of resected patients were diagnosed on their first screen. And among those screened, the unfortunate facts are that 36.8 did not have a lung RAD score documented, despite 52.3% coming from accredited programs. So although we know this modality works, and we know that patients present sooner if they are involved in these programs, we still have a lot of work to do and actually establishing the consistency among accredited programs. Most important is when we looked at focus groups within these rural populations, we saw that few were aware that low-dose CT is the recommended method, and some suggested that chest X-ray was the proper tool for screening. Participants reported receiving little to no information from their healthcare providers. They acknowledged transport as a barrier, particularly long distances and winter travel, and had concerns regarding cost and insurance coverage. And they also had reluctance in wanting to know the results. And the primary driver was fear of testing true and false positive results. But most stunning, they felt that a negative result would give them reassurance of their health and mean future screenings would not be necessary, unlike feelings that they have towards mammograms or colonoscopy, where they realize that annual or interval imaging is necessary in order to keep the cancer diagnosed at an early stage. So what do we do with this information? Well, I think there's low-hanging fruit, and then there's also bigger tasks that will need a collaborative effort between multiple institutions in order to be successful, but have the opportunity to create a cascade of positive outcomes. In terms of the low-hanging fruit, institutional efforts to increase participation are paramount. Education, both for patients, for clinicians, and including tobacco cessation, is imperative to success. Specifically for patients, having handouts with easy-to-read information so they can learn more about lung cancer screening is needed. For our clinicians, having best patient advisories or tools that will help them to educate their patients, whether it's diagrams or figures. Lastly, smoking cessation is imperative, and doing this in a patient-centered fashion while also decreasing stigma, though hard to do, is going to be imperative to increasing our positive outcomes. If we want to think outside the box and look at even bigger solutions, one angle is we can increase access through the use of mobile screening units, bringing them out into MOHAMED. This has been shown to be successful in other screening modalities such as mammography and cervical cancer screenings, and certainly this could help to increase access in underserved areas with high rates of tobacco use and incidence of lung cancer, and additionally establish whether or not screening facilities, specifically accredited screening facilities, are needed in that area, or if mobile units can meet those needs. We can characterize the care cascade. Specifically, how much does it cost for all of these extra testing that may result from screening, and what is the average number of tests a patient that undergoes screening may have to participate in? Is it one extra CT? Is it a CT and a PET? Is it 3 extra biopsies? Having answers to these questions would be helpful in both alleviating patient and provider fears. It would also decrease unnecessary testing and procedures if we had better indicators of what these outcomes of these extra testing would likely be. Angle 3, the use of artificial intelligence and machine learning to estimate lung cancer risk has been an established modality that has not yet been adapted in nationwide use, but could help decrease the number of false positive results that we get and decrease unnecessary testing and procedures as well. Last, exploring the relevant cancer biology found in screened nodules and relating that to the pathology that's found once these nodules are resected and found to be cancer can help to better estimate the risk once these nodules are seen on initial imaging studies and better educate the patients on what the next step should be. So in conclusion, we know that lung cancer screening works, and many follow-up studies to the NLST have demonstrated that. We know that one low-dose chest CT per year in patients that meet the eligibility criteria helps to reduce both lung-specific and overall cancer mortality. We know that there are updated guidelines that are more inclusive of diverse real-world populations. But we also know that we need to increase provider referral through a better education of the risks and benefits, an outsourcing of shared decision-making and telehealth. We need to increase patient enrollment by increasing better education efforts, increasing access, and decreasing the shame and stigma. And then we also need to address known barriers, along with exploring the unknown, to increase enrollment efforts and maximize treatment options. More specifically, as surgeons, we must be knowledgeable about the effects of smoking. We must know the guidelines of lung cancer screening eligibility and inform our patients, as our outcomes directly depend on this. Keeping in mind that the legalization of marijuana, hookah, and vaping threaten the pulmonary health of our youth and adults and may possibly limit resection options available for lung cancer patients due to greater severity of underlying lung disease. Yet we must continue forward. I hope this has answered your questions about lung cancer screening. Please feel free to reach out and contact if you have any further questions or concerns. Thank you for your time and attention.